Good evening, everybody. Welcome again to another one of our Worldwide WISH webinars. As you know, VIT Sport and Health has presented these webinars right through the lockdown period, and we're very grateful for your support and welcome you again to one of these academic offerings. Also, a big welcome to our SASMA members and to the SASMA president in particular, Christa Janse van Rensburg, who's a great supporter of these initiatives and is doing some great work through the association as well. Importantly, I'd like to thank some very supportive individuals. Our chairperson, Professor Helen Mjezwa, who's really been a great support and I know is on the webinar as well. And of course, Dr. Robin Saggers, who's done a lot of work in promoting and putting this program together. Thanks very much, Robin, for being in the background this evening and looking after the technical aspects as well. Very delighted to welcome back Dr. Haley DeVet, again, who gave that wonderful presentation a couple of weeks ago when WISH presented the bone health webinar. And we think that tonight's topic on the REDS in sport will really complement that very well. Again, a word of thank you to our sponsors, the Lita and Acino company, a pharmaceutical company who's allowed us to facilitate this process, and we thank them for their background support and their grant which has funded this initiative. And of course, as attendees, we encourage your participation. Please put your questions in the question and answer facility on Zoom, and we will try and filter through as many of them as possible in the Q&A section afterwards. So I'm going to mute. I'm going to invite Haley to take the microphone and introduce our very distinguished guest for this evening. So please do enjoy the talk.
Thanks, John. And yes, she truly is distinguished. And I just would like to take this opportunity to thank Kate for taking time out of, I'm sure, a very busy schedule to engage with us. I had a look at your bio and it really is quite extensive and impressive, but just a few accolades to mention to everyone. Dr. Ackerman is certified in internal medicine, sports medicine, as well as endocrinology. She's the founder and medical director of the Female Athlete Program at Boston Children's Hospital, as well as being the associate director of the Sports Endocrine Research Lab at Massachusetts General Hospital, and an assistant professor of medicine at Harvard Medical School. Dr. Ackerman is not only a physician and academic, but she's actually a sportswoman in her own right. She was a varsity rower in college and later rowed for the US national team. She's also a team physician for the US rowing. Dr. Ackerman's research focuses on the female athlete triad, as well as the REDS. She has authored and co-authored over 100 articles and book chapters, as well as presented extensively nationally and internationally. Dr. Ackerman is a member of the IOC's REDS and Female Athlete Health Working Groups and a member of the World Rowing Sports Medicine Commission. Personally, I must say I've gained great insights from some of your online available presentations, and I'm thrilled to hear you speak tonight, as I'm sure the rest of the audience is. So over to you.
Thank you for having me. I really wish that I were in South Africa. It would be fun to be hanging with all of you in person. I see some of my favorite South Africans are already talking on the Zoom chat. So I will get started. Perfect. Okay. So we're going to talk about relative energy deficiency in sports. We'll talk about some of the causes and consequences of low energy availability in athletes. And now I'm trying to click. My goodness. Why is it not moving? Okay. I have no disclosures other than what was previously mentioned, and that I work with the IOC on REDS topics and female athlete issues. So the outline for today's talk are really to talk a little bit about the history of the female athlete triad, the history of relative energy deficiency in sport, REDS or REDS, discuss a little about low energy availability, some of the consequences of REDS, diagnosing REDS, treating REDS, some considerations for return to play, and then future directions. So back in the early 1990s, there was a group of people from the American College of Sports Medicine who came together to think about how to talk about three interrelated topics. So they had seen this combination of women who had eating disorders and had amenorrhea and had osteoporosis. And one of the founding members, the grandmother of this whole topic, Dr. Drinkwater, had really noticed that there was this combination, and they came up with this term female athlete triad. And there was an ACSM position statement in 1997 that really described that triad, really talking about low energy availability, amenorrhea, and low bone density or osteoporosis. And over time, people saw that a lot of athletes can actually live on these different continuums or continua. And they said that there was really an energy availability continuum, and there was a menstrual cycle continuum, and there was a bone density continuum. So by 2007, they updated the female athlete triad position statement for ACSM, and they came up with this sort of prism and talked about how an athlete could live at different phases on those different spectra. So an athlete who's in great shape, who's eating well and doing great bone impact activity could really live on the right side of the triangle and have optimal energy availability, eumenorrhea, and bone health. It's actually better than non-athletes. But a lot of athletes would fall along those spectra and get into that dangerous zone to the left. And we really want to find our athletes somewhere before they get over there and sort of catch them as they're starting to slide down the spectrum. So in 2014, the IOC was talking about doing an update in their female athlete triad position statement. And they said, you know, it does seem to be broader than that. There seems to be effects of low energy availability that aren't just related to hormones and bone and menstrual cycles. And we also see that there are effects that can happen in men, and certainly energy deficiency can happen in our male athletes too. So they came up with this REDS position statement about the sort of a progression of triad. And then in 2018, in the interim, I had gotten the fortunate opportunity to join the group. And in 2018, we did an update on that consensus statement, sort of adding to the literature what had been done in the interim and more of a call to action for more research that was needed in a lot of different groups. So just to talk about those original diagrams, there is a health consequence diagram, a spoken wheel diagram, and we're going to go around all those different circles. So if you start in the top corner, you certainly still have the triad, which is very important. And then going around the circles, there are endocrine effects, metabolic effects, immunologic effects, growth and development issues, psychological effects that can go in both directions. So psychological effects can happen from REDS, but then psychological issues can also impact REDS. Cardiovascular issues, GI issues, and immunologic issues. In terms of potential performance effects, again, there are many. Some of these are more well described than others, but it's, again, starting in the top corner, you have increased injury risk, decreased training response, impaired judgment, decreased coordination, decreased concentration, irritability, depression, decreased glycogen stores, decreased muscle strength, and decreased endurance performance. And so one of the reasons I really thought that this was a great model is a lot of my athletes aren't quite ready to care about their bone density. They might not have had a stress fracture yet or a bone stress injury. And so when I'm telling them about osteoporosis, it's not hitting home in a young athlete quite yet. But when you start to talk about decreased training response or decreased endurance performance or just a worse athletic performance, they start to wake up. It can be another way to get at fixing the problem because now they care about some of these other consequences. So talking about low energy availability, which is really the underpinning, whether you're talking about Triad or REDS, it's important to understand where that equation came from and what it's describing. So energy availability is the dietary energy intake minus exercise energy expenditure. So the athletic expenditure, not what was needed for regular day-to-day living, but just what's needed during exercise. Normalize the fat-free mass. And so one way you can determine fat-free mass is to get a DEXA, which not only gives you bone density, but can also give you lean mass and fat mass. And so taking that information from the fat-free mass and the calculations of intake and exercise energy expenditure and plugging them into this equation. So let's say you have a female athlete and she burns 2,000 kilocalories, or she eats 2,000 kilocalories a day, and she goes for a run and she burns 600 calories, and her fat-free mass is 51 kilos. So that might be in someone who's maybe 130 pounds. She would only then have an energy availability of 27.5. And basically that's not enough to sustain all those different hormonal patterns that she needs to have. So there was work that was done by Ann Laux and her colleagues back at Ohio State University. And what she found was in women who were non-athletes, these were just adult women, when she was able to manipulate the energy intake and the exercise energy expenditure, when the number dropped below 30, there were big changes in terms of menstrual function and in hormonal patterns. So the hormonal patterns that are important for menses. So 30 became somewhat of a magic number. But really, that's probably a minimum, and 45 may be ideal, and it's likely a personal variation. So for example, during adolescence, when somebody is growing a lot, the number may need to be higher, and there may be different numbers for men and women. And so that's part of what we need to tease out, and we need to find what is the sweet spot basically for each athlete. So low energy availability can become an issue from an eating disorder, so a clinical mental disorder defined by the DSM-5 and characterized by abnormal eating behaviors and irrational fear of gaining weight and false beliefs about eating weight and shape. But then there's also disordered eating. So this could be various abnormal eating behaviors. It could be restrictive eating, fasting, skipping meals, diet pills, laxatives, diuretics, enemas, overeating, binging and purging, specific diets that eliminate certain foods. So disordered eating can be a lot of different things. And we know that the prevalence of disordered eating and eating disorders is higher among athletes than non-athletes. It is a higher risk in female athletes than male athletes, and it's a higher risk among athletes in leanness sports. And some have called eating disorders a deviant overconformity to the sport ethic. So the sport ethic is an athlete makes sacrifices for the game, an athlete strives for distinction, an athlete accepts risks and plays through pain, and an athlete accepts no limits in the pursuit of possibilities. So these are tough people. These are people that are very driven and motivated and disciplined. And so often an eating disorder can be using those same characteristics and taking them into a bad place where really the athlete is putting themselves in danger. But I also think it's important to think about other types of athletes, so endurance athletes. And as a rower, I'm going to put some rowing topics throughout this talk. So endurance athletes are also susceptible to REDS. So there's an increase for many reasons. There could be cyclical changes in body mass and composition, so making weight. This can happen with wrestlers. This can happen with lightweight rowers, anybody that needs to make a certain weight class. There can be prolonged inadequate energy intake to meet high exercise energy expenditure. So very long endurance rows, working out, preparing for the Olympics and working out 3 or 4 times a day. Certainly there are going to be times when it's just hard to get calories in for the amount of exercise that's being done. Abrupt changes in training volume and intensity, participation in strenuous endurance events without changing nutrition, inadequate food availability, including food insecurity from cultural practices or lack of financial resources. And basically, we have to keep in mind that the prevalence of low energy availability and eating disorders can vary from different groups and also depending on how it's measured. So for example, 15 to 62% of female high school and collegiate athletes have disordered eating. That's a huge span. But part of the reason for that is how the questions are asked. So was it self-report by a questionnaire? Was it an in-depth interview? Was there 2-stage screening where there's a questionnaire and then a follow-up interview? What's being asked? So there's different ways to tease out the questions. Who's asking? Is it just a requirement that the coach needs to screen their team? Or is it in more private with the trainer or the doctor? Are the athletes afraid of the consequence concerns? So certainly there's a lot of different ways that this is measured, and that's why these numbers become so skewed. We did a survey of 1,000 female sports medicine clinic patients. So this was at Boston Children's, and we had athletes coming in and screened those who were 15 to 30 years of age. They were all women. We made sure we defined athlete as equal to or greater than 4 hours a week of exercise, and it needed to be purposeful exercise, and they needed to be a member of some sort of sport or team. And we used a surrogate marker. So we decided that it's very hard to screen about eating disorders. So we'll use some questionnaires and we'll just straight up ask them if they have an eating disorder or disordered eating. And on the right, you can see there's this Venn diagram. So the disordered eating or eating disorder was self-report. Then we used the beta Q down in the left corner. That's the brief eating disorder questionnaire for athletes. And then over on the right, that's the eating disorder screen for primary care. So we asked these 1,000 athletes all these questions about their attitude about food and eating. And you can see that only 68 of the 1,000 screened positively on all 3. But actually, if we counted any of those as a positive screen, we actually found that 47.3% of our athletes coming in for a variety of reasons, it could be concussion, ACL injury, ankle sprain, all sorts of different things. 47.3% of our female athletes screened positive for disordered eating, using that as a marker then for low energy availability. We had a pretty good response rate because I guess we make our patients wait a lot in the clinic, or they were just interested, or both. So I'd say this is a pretty good reflection of what we're seeing in our clinic. And frankly, it's a disturbing number to see that that many women are struggling, or that many young girls are struggling. So the adult elite athletes who have been diagnosed with disordered eating and eating disorders have reported started dieting and developing problems during puberty and adolescence. So peak onset is in adolescence, and that's when females especially experience rapid changes in their body composition and their shape. And at least in our country, when we see girls going from middle school to high school, this is when they're really increasing their volume of their training. This is when they're getting more serious about their sport. And this is also when they're going through puberty and having all the other fun things that go along with that. So it's a real pressure cooker. It's a really stressful time for kids as they're trying to figure out who they are, and they're having issues with their body image and trying to be competitive athletes. If we focus on the right, so now we're going to focus on the triad up in the corner. The original concept with the female athlete triad was negative energy balance, leading to disruption of the hypothalamic pituitary ovarian axis. So initially it was thought to be low estrogen, leading to low bone mineral density. And that is definitely a component of this. And back to the Laux study, basically she found that after a few days of decreasing energy availability from 45 and then down to 30 and then dropping it, there was this dose-response relationship between energy availability and LH pulsatility. So as the energy availability went down, LH pulsatility did change, and it became less frequent, and the amplitude changed as well. But what was also interesting here was that as energy availability dropped below 30, bone protein synthesis and mineralization decreased, insulin, which enhances amino acid uptake, decreased, IGF-1, which is an important form of growth hormone, decreased, and T3, one of the thyroid hormones, also decreased. And all of those changes occurred within 5 days of the onset of energy deficiency and without a reduction in estrogen concentration. So all of the effects that we're seeing on bone are not just mediated through estrogen. In fact, everything on this slide is actually related to bone, and everything on this slide has a disruption when low energy availability occurs. So I highlighted some of the most important ones. The ones in green have a positive prediction, a positive effect on bone, and the ones in red had a negative effect on bone. And so you can see that when somebody has low energy availability, they have a decrease in lean mass, FSH, LH, estradiol, and androgens, a decrease in IGF-1 and leptin, and they have an increase in fasting PYY, ghrelin, cortisol, and growth hormone resistance. So everything is kind of moving in the wrong direction. So we did a study looking at amenorrheic athletes, eumenorrheic athletes, and healthy controls. And we looked at their bone density, and in those pictures in the bottom left, those are pictures from something called high resolution peripheral quantitative CT, or HRP-QCT. And that's a picture of the tibia. And we can get that 3D image and looking at it cross-sectionally, and then look at that 3D image to look at the cortex and look at the trabeculum and be able to measure a lot of things like the spacing between the trabeculi, et cetera. So we looked at these athletes who were amenorrheic, we looked at the ones that are eumenorrheic, and we looked at non-weight-bearing athletes. And we found that athletic activity in general increased the cross-sectional area of bone. So basically all of that running during youth, because these were people who were 14 to 25, that caused the bone to grow and expand, and so expanded the moment of inertia. But in the amenorrheic athletes, there was a decrease in the trabecular number, a decrease in the cortex, the cortical thickness, and that led to a decrease in the trabecular and total bone mineral density. Then we were able to apply a finite elemental analysis program, which is basically to test strength, and that's called FEA. And basically we found that there was a decreased stiffness and failure load. So those amenorrheic athletes had wider bones, just like the eumenorrheic athletes, but the bones were weak. And particularly we noticed these differences at the radius, which isn't a weight-bearing bone in a running athlete. So certainly the differences were magnified at the radius. So when we talk about some of the different hormones, IGF-1 is a very important one. And from prior work, we know that IGF-1 is lower in amenorrheic athletes compared with controls, and it predicts bone mineral density. So what we see here in this graph to the left is basically IGF-1 and the levels in amenorrheic athletes, eumenorrheic athletes, and controls. And IGF-1 was much higher in controls. IGF-1, a form of growth hormone, is important for bone formation. Oops. Sorry, I'm gonna get my mouse back. We know that oral estrogen, so when estrogen is taken as a pill and it's swallowed, it has first pass metabolism to the liver. Oral estrogen actually suppresses IGF-1. So that's not a necessarily good thing if we're trying to enhance bone. But transdermal estrogen in the form of a patch does not suppress IGF-1. So when estrogen is taken as a patch, it doesn't have that first pass to the liver. And we have found that there was actually an increase in bone mineral density in amenorrheic athletes who were given that transdermal patch. So here's a graph from our publication, the British Journal of Sports Medicine. This is looking at our amenorrheic athletes who either received the patch, a birth control pill, or no estrogen. So the patch is in gray, the pill is in the slashed, and then the no estrogen is in black. And you can see the percent change in bone mineral density at the lumbar spine, femoral neck, and total hip was significantly better in those who received the patch, particularly as it compared with the pill group. And this is why one of the biggest take-home messages of this talk is that when you have an amenorrheic athlete who has low energy availability, the answer is not to put them on the oral contraceptive pill. That will not help their bone density. It could actually inhibit it. It's not getting at the energy availability problem, and the way that you're giving estrogen isn't actually beneficial. So moving on to other health consequences, we can go to more of the endocrine system. And this is a review article that we did that was in IJSNEM, so I won't spend too much time on this, but it was to compare the endocrine changes in males and females and some of the patterns that we found, just summarizing the literature. So we know in both sexes, testosterone is typically goes down with low energy availability. Notice that there's an up arrow under the females, and that's because some of the studies didn't control for amenorrheic athletes who may have had PCOS. But in general, if the energy is suppressed enough, you typically see a decrease in testosterone both in women and in men. Resting metabolic rate and leptin were down in both sexes. Oxytocin and insulin have been shown to be down in both sexes. T3 and free T3 are down in both sexes. And growth hormone goes up because there's an increase of resistance of growth hormone, particularly at the liver, again, causing there to be less IGF-1. So if we look at the thyroid, there's a study that had 32 subjects. It was a cross-sectional study. They found lower T4 and T3 in amenorrheic athletes versus eumenorrheic athletes in healthy controls. Another study had 27 subjects looking at amenorrheic athletes, eumenorrheic athletes, and healthy controls. And the TSH response, the thyroid releasing hormone, so remember TRH comes from the hypothalamus and that stimulates the pituitary to make TSH. So the TSH response was blunted in those amenorrheic athletes versus eumenorrheic athletes. In a study with 27 eumenorrheic non-athletes, 4 days of exercise, so these athletes were given, these were just normal people, non-athletes. They were given 4 days of exercise, but then had energy availabilities that were manipulated. So there was a decrease in T3 and free T3 when the energy availability was between 19 and 25. And then when that energy availability was manipulated, so it was even lower, so between 10.8 and 19, there was actually an increase in T4 and an increase in reverse T3. So this looked like an even more sick euthyroid type picture. Going back to my rowers, so in a study with 17 collegiate female rowers, they had labs at baseline and during 20 weeks of training. 10 of those rowers had decreases in free T3, they were considered responders, and 7 had no change. In the responders, free T3 concentration decreased from baseline during an intense training period of 5 weeks and decreased by 28.2%, and at 10 weeks it was a decrease of 24.9%, and then returned towards baseline by 20 weeks. There were also similar changes in leptin and TSH. So again, it depends on the training load. It depends if the athlete was compensating with their nutrition enough, but T3 was a good marker. In another smaller study of 6 male rowers, they had high intensity resistance training for 3 weeks. and leptin, TSH, and free T3 were down. They had endurance training for 3 weeks, and that caused TSH to go up. And then there was a depression of leptin and hypothalamic thyroid axis that was associated with the training intensity. So we are seeing this in different sports populations, and we are seeing this thyroid pattern in both women and men. When we talk about metabolic effects, there was a small study of normal weight women. They had different exercise and caloric intake alterations for 3 months. So there was the severely energy restricted. They were down about 1,000 calories per day. There was a moderately restricted. They were restricted, lacking about 600 calories per day. And then there was a group considered the balanced diet group. So weight loss occurred in the severely restricted and the moderately, but significantly less than was predicted just based on the numbers. And resting metabolic rate decreased by about 6% in the moderately restricted. In the severely restricted, the RMR, that resting metabolic rate, did not change for the entire group, but those whose resting metabolic rate decreased lost more weight and had a higher baseline RMR than those whose resting metabolic rate did not decrease. There were the expected changes in leptin, T3, IGF-1, and ghrelin that occurred only in the severely restricted. So there needed to be a significant decrease in energy availability to really see those hormonal patterns. The energy deficit and adaptive changes in RMR explained 54% of the weight loss. So in another study looking at rowers, 10 Australian team rowers were looked at for 4 weeks of training. Their training load increased by 21%, but the caloric intake didn't change. So when you look at that, looking at absolute RMR, here were people that were training a lot more. They had free access to food. So there wasn't a restriction of their food based on what they were allowed to eat. It was just that they were training so much, they weren't really compensating enough with their caloric intake. And the RMR actually went down. So their bodies were trying to hold on to whatever they had. And the relative RMR also went down. Talking about the immunologic system, people have proposed that this relationship, like the psychological relationship, can go in 2 different directions. So many athletes with reduced energy availability have iron deficiency. Iron deficiency may worsen the hypometabolic state associated with decreased energy availability. So T4 synthesis and T4 to T3 conversion require iron. Iron deficiency may promote energy deficiency. It does shift ATP production from oxidative phosphorylation to anaerobic pathways. And iron is also needed for reproductive function, follicular development, and corpus luteum function. Bone health may also be further impaired by iron deficiency. So this is one diagram that was put together suggesting maybe iron deficiency should be part of the triad as well. It definitely is part of the REDS model. Growth and development, I think most of us can understand this concept when we've seen athletes in clinic who are very young and are already involved in high intensity training and in leanness and aesthetic sports. So this is a growth chart of one of the dancers that I saw. And you can see she was so young and she was dropping off her growth chart when she was 12 because she wanted to be a prima ballerina. So her weight started to drop and she stopped getting taller until we convinced her and her family and did a lot of work with her to try to get her to grow some more and to eat more. We also have to remember that sometimes low energy availability can come from food insecurity and not having the access to food. So when people are getting started in a lot of different sports and they're doing huge volumes of training, we have to make sure that we have food available for them to keep up with those energy needs. In terms of psychological issues, a study looking at drive for thinness found that when it was assessed in exercising and in sedentary women, they were able to use the eating disorder inventory. The athletes with a high drive for thinness versus athletes and non-athletes with a normal drive for thinness scored higher on questions regarding bulimia, ineffectiveness, and cognitive restraint. They experienced more oligo and amenorrhea versus the other 2 groups. And they had lower resting energy expenditure and actual resting energy expenditure over predicted, and were more often classified as energy deficient. They had lower T3, which is the pattern here, so lower total T3 and higher ghrelin. And there was a significant negative correlation between drive for thinness and total T3 adjusted for resting energy expenditure. There was also a positive correlation between drive for thinness and ghrelin. Looking at adult lightweight male rowers, high levels of cognitive control of eating accompanied with body dissatisfaction occurred under states of hunger, but not during satiety. In terms of the cardiovascular system, we know that postmenopausal women have decreased levels of endogenous estrogen that unfavorably modify lipid levels and vascular function. Premenopausal women with anorexia nervosa and athletes with amenorrhea have evidence of elevated lipid levels. So theories for this interaction include estrogen deficiency, liver dysfunction, dehydration, reduced cholesterol turnover, decreased T3 again, and delayed cholesterol metabolism. Retrospective data suggests development of early coronary artery disease in some older premenopausal women with a history of functional hypothalamic amenorrhea. We know that estrogen stimulates the vascular endothelium, leading to increased endothelial-derived nitric oxide, which then allows for vasodilation. So this is obviously important for exercising muscles. So estrogen is very important to keep nitric oxide working effectively to lead to vasodilation. It also has anti-atherosclerotic properties. So nitric oxide inhibits platelet aggregation, smooth muscle proliferation, leukocyte adhesion, and LDL oxidation. Both estrogen and regular aerobic physical activity are independently associated with enhanced synthesis and/or the bioavailability of endothelial nitric oxide. There's something called flow-mediated dilation that helps us study this, so FMD, and it can assess endothelial function in the brachial artery. And there's actually a 95% positive predictive value of abnormal brachial dilation in predicting coronary endothelial dysfunction. So when we measure the flow-mediated dilation in the brachial artery in the arm, this actually can serve as a surrogate marker for what's actually happening at the heart. We know that flow-mediated dilation is lower in amenorrheic athletes versus oligomenorrheic athletes and eumenorrheic athletes, and that serum estrogen levels positively correlated with this vascular function. Restored vascular function was associated with an increase in estrogen levels in amenorrheic athletes who became eumenorrheic athletes. So once they got their menstrual cycles back, they got their estrogen levels up, and then the vascular function was restored. Moving on to the GI system, there's been less work in athletes on this topic, but in a systematic review of 123 articles of patients with anorexia nervosa, they have evidence of delayed gastric emptying, increased intestinal transit time, and constipation. They also have an increase in liver enzymes. So I've seen a lot of female athletes who've come into my clinic, and separately, as we teased out who else they were seeing at the hospital and what other medical problems they had, they frequently mention that they have constipation or bloating, and they're seeing a GI specialist about this, and they haven't really put it together with their eating disorder or their low energy availability. In our study, back to our 1,000 female athletes and our surrogates, we found that those who had low EA had 1.5 times greater odds of GI complaints with low energy availability versus the adequate energy availability group. In terms of immunologic function, there have been a few small studies. So athletes with high training loads often experience impaired immune function and frequent upper respiratory infections. Decreased salivary IgA correlates to an increase in upper respiratory infections, and salivary IgA correlates with salivary estradiol. So in a study of 21 Japanese elite collegiate runners, 13 amenorrheic and 8 eumenorrheic, salivary IgA levels, serum 17 beta estradiol and progesterone, and the number of upper respiratory infection symptoms in the last month were recorded. The amenorrheic athletes had lower levels of serum estradiol and IgA secretion and more URI symptoms. In a different study in elite Australian athletes prepping for Rio, low EA was measured by the LEAF-Q. So this is the low energy availability questionnaire for female athletes. And there was an increased odds of illnesses, so upper respiratory and GI tract issues, body aches, and head-related symptoms in the prior month in those with low EA. So let's move on to some of the potential performance effects of REDS. This is a great study that I like to talk about a lot with my athletes. So this was 10 junior elite female swimmers. They were 15 to 17 years old. They were grouped into cyclic, those who got their menstrual cycles, or ovarian suppressed. And so the cyclic and ovarian suppressed were determined based on their estradiol and their progesterone levels. They were monitored every 2 weeks over 12 weeks. The ovarian suppressed had suppressed estrogen and progesterone throughout the season, and they had a decrease in T3 and IGF-1 at week 12 versus the cyclic, those who got their menstrual cycles. But most importantly, energy intake and energy availability was lower in the ovarian suppressed, and they had a 9.8% increase in their 400-meter swim time, while the cyclic had an 8.2% decrease. So this I love to talk about with the athletes that I see, because here's a group of young people training for 3 months, doing the exact same workouts on the team together, and the ones who weren't getting their menstrual cycles, who had low energy availability, actually got slower, and those who did the 12 weeks of training, who were fueling appropriately and got their menstrual cycles, got faster. And if that is the point of training, to get faster, it's unfortunate that those who were amenorrheic were really not making progress. In our survey, there was a 1.47 times greater odds of decreased endurance performance in those with low EA versus adequate EA. Back to our 10 Australian team rowers. So these were the ones who did the 4 weeks of training, really high intensity training, weren't able to keep up with their caloric intake and had a change in their RMR. Their energy intake just stayed the same. They didn't realize that they needed to be eating so much more. And in fact, exercise, intense exercise can suppress hunger. So these people were probably just so tired from their training. They didn't realize they needed to be eating past fullness. They didn't have the same hunger cues. And so they weren't eating any more than they were when there was a lower training load, and they actually became slower. So their 5K time after all of that training got slower as well. So it even happens at the very elite level in people that aren't worried about nutrition or body image, but just aren't getting the calories in. We looked at injury risk and talked about bone stress injuries in our amenorrheic athletes, eumenorrheic athletes in our non-athlete study. And we asked them about their history of fractures. So this is just a graph of the stress fractures, and they were to recall when they had stress fractures, how old they were, and the number that they had had. So amenorrheic athletes are shown in black, eumenorrheic in the white bar, and then the non-athletes are in gray. You'll notice there are no non-athletes on here because this is stress fractures, and those come from a repetitive activity typically, and our non-athletes weren't exercising much. So we just have amenorrheic athletes and eumenorrheic athletes. And the eumenorrheic athletes did have this window where they had some stress injuries. And that's about the time when people are growing. So we know that as adolescents grow, their bones lengthen and they don't mineralize as quickly. So the peak height velocity hits before the peak of bone mineralization. So there's this window of transient osteopenia where people are more susceptible for fractures. But in the eumenorrheic athletes, they grew out of that phase and then they didn't continue to fracture, while our amenorrheic athletes continued to fracture. We applied our DEXA and our HRP-QCT to that group, and we also divided up the number of stress fractures. So we don't necessarily need to do a bone workup on every single patient, but I wanted to find sort of a clinical relevant point. So these are amenorrheic athletes who had 0 to 1 stress injuries or fewer than 2, and then amenorrheic athletes that had 2 or more. And you can see when there were 2 or more stress injuries, the lumbar spine and whole bone mineral density scores were lower. There were a lot of changes at the HRP-QCT radius, where we see more of a magnification of the differences in bone because it's not weight bearing. And there was worse stiffness and failure load in those with 2 or more stress injuries. So this is where I like to use a cutoff, and this is applied now. It's kind of woken up some of our surgeons who see patients and aren't always thinking about bone workups. When they see an athlete in sports medicine clinic and they've had 2 or more stress injuries, they're now more likely to ask about menstrual history and fueling, and then we tend to do more bone workups and look at the nutritional approach of a lot of these athletes and catch more of these REDS cases. In terms of decreased muscle strength, there was a study of neuromuscular performance that was assessed in elite amenorrheic athletes and eumenorrheic athletes. The knee muscular strength and knee muscular endurance was worse in the amenorrheic athletes, and the reaction time was longer versus the eumenorrheic. There was a decrease in leg fat-free mass, glucose, estrogen, T3, and an increase in cortisol levels that correlated with the findings. So again, following the same patterns that we typically see in REDS. So how do we diagnose low energy availability? So when we're just focusing on low energy availability or REDS or eating disorders, just underfueling in general, we have to have a good suspicion. So different clues that we could see in clinic would be weight loss. So is the person fallen off their growth curve? Do they have a low BMI? So BMI isn't everything, but that's a start. So is their BMI, I say for the adults, below 19.5 is a little bit of a warning sign. But in adolescents, you know, they tend to have lower BMIs, so it's not a perfect cutoff. Abnormal thyroid function tests, decrease in white blood cell count, iron deficiency, these can all be areas where you can do some further questioning. Bradycardia, a decline in performance, a change in mood, frequent injury or illness, fracture or low bone mineral density, menstrual dysfunction, or a poor score on an eating questionnaire. These are all things that should be a bit of a red flag to make you ask more questions. These are some of the physical signs that you can see in somebody with an eating disorder. So they might have a lot of dental caries. They could have changes in their EKG. They could have sinus bradycardia. They might be complaining of decreased intestinal mobility or constipation, delayed gastric emptying. They might have on their labs hyponatremia, hypernatremia, again, amenorrhea, oligomenorrhea, delay in puberty. On our very thin runners or very restricted athletes, we start to see hair loss. We start to see lanugo, that soft hair on the face. I often will see athletes who are really focused on snacking with carrots or having sweet potatoes. And so their skin actually changes color because of the hyperkeratinemia. And so you can see in their hands tend to be very orange. And then hematologically, you might see just a full suppression, anemia, leukopenia, neutropenia, and thrombocytopenia. So this whole slide, it's from an old article that was in New England Journal of Medicine back in 1999, talking about eating disorder signs, and just getting more familiar with these will help you just see the syndrome a little bit better. In terms of menstrual dysfunction, not everyone's going to tell you they don't get their period. And so many of our athletes, our female athletes, are struggling with this, and many more are coming forward, which has been really great because they're normalizing the issue and talking about it more. You want to suspect menstrual dysfunction when someone admits to having an eating disorder or disordered eating, if they have a low BMI, if they have delay in developing secondary sexual characteristics, if they've had weight loss, if they've had a stress fracture. So always think about this in terms of a stress fracture. Diagnosing low bone mineral density. Another way to suspect it is if somebody says they have malabsorption syndrome, if they're complaining of irritable bowel, if they have a known diagnosis of celiac, if they have an eating disorder, stress fractures, or menstrual dysfunction. So a lot of different things need to be in the differential once you find out that they have low BMD, but there are other things that should just be a clue that you should check for low BMD. So what is the workup? It really depends on the patient, but it always starts with a good history and physical exam. So talking about the diet with the athlete, talking about the training, certainly having a sports dietitian involved who can really do a deeper dive in terms of nutrition and determining the caloric needs. Talking about medical conditions that the person might have, such as celiac or other malabsorption issues. Family history, other family histories of eating disorder or other problems. Reproductive history. So I've seen adult patients who have actually done IVF and have had fertility assistance, and the doctor hadn't gotten to the fact that this person was just underfueled and was a marathon runner and was suppressing their hormonal axes, but instead these women have actually gone through fertility treatments rather than addressing energy availability because nobody put that together for them. Did they have delayed periods? Have they lost their menstrual cycles? Do they have a lot of stress? Stress alone can suppress the hypothalamic pituitary hormonal axes. And then medications, there's a variety of medications that can also disrupt hunger, stimulants. Think people who have ADHD and are on stimulants often don't have as much hunger, and so they're not getting the calories in simply because they're not getting those hunger cues. There's a variety of medical testing depending on what you find, various labs, bone density. If they have a bone injury, you could be doing an MRI or a bone scan. If their heart rate is very low and you're worried about extreme eating disorder symptomatology, EKG certainly is important. So that's a whole other talk in terms of the labs, but we have resources that we can talk about for the workup. I'd say the most important thing is to get used to recognizing it. So on the right, those are pictures of DEXAs. And if you can get that whole body DEXA, the software can tell you bone density, fat mass, and lean mass. And so the picture on the top is a female, the picture on the bottom is a male. And notice in both of these pictures, there's very little fat. So I have patients who have absolutely normal body mass indices and don't have much fat, and so their hormones are suppressed. I saw a hockey player who had a BMI of 22.5, and she basically had no fat on her and hadn't had her period in years. And so she just didn't realize, she didn't think she fit the type of somebody who would have hormonal suppression and have disordered eating. She just thought she was muscular, but we had to just re-educate her about how much she needed to eat. There are a lot of different things that can be signs. So does the female have low FSH, LH, low estradiol? Does the female or male have decreased libido? Does the male have low testosterone? This is an awkward question, but you need to ask male patients if they're young, if they're waking up and they no longer wake up with morning erections. That is a typical physical response for a male in the morning, and a male will typically know that that has changed or hasn't happened to them in a long time. That demonstrates low energy availability. They could have low white blood cell count, low iron, low ferritin. I love to check ferritin on my athletes because it's often low, and then it's a gateway for them to go see the dietitian, because most of my athletes care about their iron levels and their ferritin. They know that that's important for performance. Low T3, low vitamin D, increased LFTs, altered lipids, all of those can be signs that REDS is happening. They could have decreased performance, decreased bone density, low BMI, low fat mass, like we talked about. The treatment, I have to emphasize, is definitely interdisciplinary. So we have a lot of different specialists working at different angles. I'm a sports endocrinologist, but there can be a sports physician, a family practice doctor working in consultation with an endocrinologist, or just a primary care physician who's very familiar with this entity. Our sports dietitians are really vital to the team because they can take the time to make the adjustments in terms of nutrition. A therapist, it's often very hard to get an athlete to gain weight and accept that they need to change their body composition because they've worked so hard to get their body to where it is. So talking about the goals of training and the goals of recovering from REDS, that can be very important. And the more you can get other members of the team involved, the better. Just more support. An exercise physiologist to explain some of the changes that are happening. A coach who's supportive and not part of the problem. Teammates who understand that the athlete's struggling. Keeping the athlete involved in the team as much as it is safe to allow them to feel like they're still part of the group as they're recovering. The more the merrier. It's just about finding people that are all sending the right message and supporting the athlete as they improve. So a little bit about DEXA. When we use a DEXA in children or adolescents, we always want to get a bone age. So we want to compare their bone, their bone age to people of their age. We want to compare their DEXA to either their bone age or their chronologic age. If their bone age is below their chronologic age, then we use the bone age as the interpretation for the bone density. If their bone age and their chronologic age are the same, great. If one is older than the other, you have to adjust it and do it off of bone age. So somebody who's extremely delayed because they're underfueled may often have a low bone age. The scores that we're looking for are a Z-score. So a Z-score compares their bones to people of their age. Somebody who has a DEXA who's 12 is going to have less bone mineralization than someone who's 20. That's why we use the Z-score. So we use the Z-score in premenopausal women and in children, and we use the Z-score in men under the age of 50. So a lot of the people that we're talking about, we use Z-score. In terms of what part of the body we scan, I like to do the whole body whenever available to get the body composition. But in general, in kids up until age 20, use the whole body and use the spine. In adults, for bone density purposes, the sites you're looking for are the spine and the hip. You don't use the hip in kids because the hip is still growing and developing and it changes over time. So it's hard to compare and get normative data at the different ages and the different stages of development. So in general, for an adult, you want to look at the spine and the hip. For a kid, you're looking at the whole body and the spine. And if you care about body composition, you need the whole body. So let's talk about some of the potential treatments for low bone mineral density. And it sounds like you've already had a bit of a talk about this, so I'll go through it quickly. But basically, birth control pills, there are a lot of data limitations. Studies of efficacy of oral contraceptive pills on bone mineral density are not definitive. So some showed an increase, some showed no change, and some showed a decrease in bone mineral density. The FHA, or the Functional Hypothalamic Amenorrhea Guidelines from the Endocrine Society, recommend against their use for bone. What about androgens or IGF-1? So in female athletes, these were actually females with anorexia nervosa. They were given testosterone and DHA replacement, and those are two types of androgens. There were changes in bone turnover markers, but there were no improvements in bone mineral density. And when DHEA, a form of androgen, plus oral contraceptive pills were given to adolescents and adults, young adults with anorexia, it prevented a further decrease in the bone density, but it did not increase bone mineral density. So they didn't have the same kind of bone accrual as in somebody who was normal weight with normal eating. In terms of recombinant human IGF-1 and oral contraceptive pills in anorexia, there was an improvement in lumbar bone mineral density, but it has not been tested in young women with Triad or RED, so it's not a mainstay of treatment. What about leptin? So there were 20 amenorrheic female athletes randomized to recombinant leptin or metroleptin or placebo. So the lumbar spine bone mineral density trended higher at 9 months in the treatment group, but in the subjects who completed the entire 2-year study, metroleptin significantly increased bone mineral density, but the N was only 4. And part of the problem was that leptin actually can lead to weight loss. So there's a negative effect in terms of hunger, and people lose weight when they take leptin, and leptin's dosing needs to be titrated a lot during the process. And in these studies, basically there was a lot of dropout. So this is not a recommended treatment. Bisphosphonates are anti-resorptive agents that inhibit osteoclast function. Low energy availability in amenorrhea can both increase bone loss and suppress bone formation, but bisphosphonates do not address the issue of reduced bone formation. There's a long half-life of the drug. It can stay in bone for up to 10 years, and it has a teratogenic risk. So it definitely should not be used in our premenopausal females who may want to have children. Sometimes there can be a role for the bisphosphonates in male athletes, but again, we always want to be focusing on the nutritional component here. In general, in females, and we haven't studied it in REDS and Triads, so we should avoid it in our female athletes as much as possible. Finally, we have teriparatide, and in the US, this drug is called Forteo. This is basically an anabolic agent used in some forms of osteoporosis. It's used off-label to accelerate fracture healing. There was a study of 21 adult women by a friend of mine over at MGH, Puna Fazeli, and she looked at women with anorexia nervosa and randomized people to teriparatide or placebo. And at 6 months, lumbar BMD increased significantly more with the treatment. But we still haven't done studies in Triad and REDS. It's not appropriate for adolescents because it needs to be used in people after their growth plates are closed. And we don't know what the long-term effect is. So in adults who are older, we usually follow up Forteo with a bisphosphonate because it builds up bone density. And in those postmenopausal women who don't have estrogen, we then give them a bisphosphonate to help maintain the changes that were found with the Forteo or the teriparatide. But in premenopausal women, it's hard to know what happens. So we need to do more studies following them after they have that teriparatide treatment. So again, this still isn't standard of care. So then we get back to our study of transdermal estrogen, and this is getting more widely accepted based on this paper. Again, we saw improvements at 6 months and a year with the patch. So we saw improvements at the lumbar spine, the femoral neck, and the total hip. So this can be a nice adjunctive therapy in addition to increasing energy availability in amenorrheic athletes who have low bone density. So if I have a female athlete who's really struggling to make the lifestyle changes to gain weight and her bone density is low, sometimes we want to put literally a Band-Aid on the problem for a while as we're changing that approach to her nutrition. And this can help protect the bones in the interim. So you might try this for 6 months as the person is trying to gain weight. Then as they've become weight recovered, take the patch off and see if they get their cycle back on their own. So this brings me to the return to play approach. And this is the return to play approach by the Female Athlete Triad Coalition. They came up with a scoring system. And so they used different risk factors. There was the low energy availability with or without disordered eating or an eating disorder, low BMI, delayed menarche, oligomenorrhea and or amenorrhea in the last 12 months, low bone density based on the DEXA, and then a history of stress reaction or fracture. And they gave each of these categories points. So there was low risk, moderate risk, and high risk depending on the severity of the issues. And then they decided that each of these points would add up to a score, and you could put somebody into categories based on their cumulative risk score. So if it's a pre-participation exam and you have DEXA availability, somebody could have full clearance if they had 0 to 1 points, provisional clearance if they had 2 to 5 points, meaning that they would then have a treatment team and would have certain things investigated further. And then restricted for training would be equal to or more than 6 points, restricted from training and competition, or even disqualified. So this point system has been tested in various athletes, and they also have a lot of caveats. And as painful as this slide is, it's important because we have to keep in mind that people are in different situations. Is this 2 weeks before the Olympics? Is this somebody who's 30, or is it somebody who's 14? That might change how aggressive you are. Is this person on scholarship? Do you have the authority to actually disqualify somebody, or are you seeing them in clinic? What's the psychological state of the athlete? So there's so many things that need to be taken into consideration. This is strictly guidance. And then there's the IOC's REDSCAT, or the IOC REDS clinical assessment tool. This one does not have a point system. Basically, it says certain things are high risk, red light, no start, a big problem. So somebody with a serious case of anorexia nervosa, I don't care how many points they add up in those other columns, that's somebody that's very concerning. Or somebody who has severe EKG or ECG abnormalities, I don't care about the number of points. If they have something abnormal on their EKG, I'm stopping right there. In terms of the moderate risk, same idea. If there are certain things in these different categories that are of concern, that's enough to put them into that yellow light category, modify their training, and make sure that they have a treatment team and that you're investigating. So I like that this one doesn't have a point system, although now there are a lot of things to consider. And pros and cons of both of these, we could have a whole discussion on, but I think that there's probably a happy medium where we're combining these two screening tools. So let's just end with a couple cases. Teenage female athlete. So when you have a teenage female athlete, basically you need to be aggressive if they have an eating disorder, if they have not had their period by the age of 15 and a half, if they have had 2 or more stress fractures, or they have fallen off their growth curve. This is some person that you really want to be intervening on soon, because you can make a big difference and you can turn this around. So be aggressive in the beginning, and hopefully this doesn't become a lifelong problem. For teenagers, we really want to think about BMI in a different way. So when we have young people, we have to use things like percent median BMI or BMI Z-score, because BMIs in kids, as I mentioned earlier, are different than how we approach them in adults. It's really more of a percentage. So this is from an adolescent medicine paper in 2015 to kind of talk about how we approach the BMI, giving it a Z-score like we do for bone. So here's a case of a 13-year-old dancer who was referred to me for bone health eval. She had a BMI of 13.8. Her BMI Z-score was negative 2.62. So if you go back, you can see negative 2.62 would be in that moderate category. So that's of concern. Her percent median BMI was 74.2. Again, that would put her in that moderate category. She has primary amenorrhea, which isn't unusual because she's 13, so we don't expect that she would have gotten her cycle yet. However, her mother got her cycle at age 12. She's had 1 stress fracture, but she's fallen off the growth chart. She has not been growing recently, and she is described as a picky eater. So if we put her into the chart, she gets high risk for how restricted she's being about her eating. Her BMI is very low. We can't really give her points for delayed menarche or oligo or amenorrhea because she's not really, relevant to that because of her age. But her bone density was low, and she'd had a couple stress fractures, so we give her a score of 8. So she's still high risk. So in this case, she already had an adolescent medicine doctor. They were doing family-based treatment, which is basically when the family is involved and they give different, the parents plate the food, they're in charge of the meals. They had a dietitian, which isn't typical for family-based treatment, but I think is really great that they already had a dietitian involved. The mom wanted a second opinion. And so basically what we did is we reinforced the messages from the other providers. They thought they were going to get a different set of instructions because they came to a sports clinic, but it was really important that we had a united front. So the DEXA and the bone age was just more proof of the health detriments that this athlete had. She had slow weight gain. She ended up getting 4 more stress reactions and fractures all at once because she wasn't really following the plan. The parents weren't really reinforcing what we were saying. They tried to have this good cop, bad cop situation, and I was frequently bad cop. And eventually she needed to get to a higher level of care, and she was admitted for her eating disorder. She was young, and we needed to be aggressive up front. Another case is a 21-year-old lightweight rower. She competes at a weight of 129 for a 130-pound weight class in college, and she wanted to train for the US team. So to compete on the US team as a lightweight, the average is 125.6. So to be in a team boat, she would have to lose even more weight. But this was at the end of her college career. This was pre-COVID, college was happening, rowing is a spring sport. So she had a couple more months of her college career. She had a BMI of 19.5, 5 periods a year, menarche at age 16, admits to restricting some in high school and restricting carbs to lose weight in season, had a tibial stress fracture in high school with track, and then had a rib stress fracture her junior year of college. And her lumbar BMD Z-score was negative 1.8. So she had a lot of points. Here she had basically some dietary restriction. Her BMI was 18.5. She got her period late. She'd had fewer than 6 periods a year. Her bone density was between -1 and -2, and she'd had 2 or more stress injuries. So she had a score of 8, which according to this means we should completely restrict her. But that's a little hard 2 months before she's about to graduate college and she's the captain of her team. So what we decided to do is follow up with a sports dietitian to help her increase her caloric and carb intake as much as she could to stay in that weight category she needed for college. We decided to consider an exercise physiologist to see if she could discuss mild weight fluctuations with training and really use the DEXA results to determine her body composition to see if rowing as a lightweight in the future was even practical. Was it realistic? Was it safe based on her body composition where it already was at 129 pounds? We recommended a metabolic bone workup. We did that trying to optimize her calcium, her vitamin D, making sure there were no other causes for her bone density being a bit low. We recommended a sports psychologist to discuss goals of eating and of training. She wants to be on the national team as a lightweight, and basically we're getting to the decision that she probably should not be a lightweight. So that's going to be a real adjustment for her. That's her identity. And then we considered transdermal hormonal therapy down the line if her menses didn't come back, to just help her bone density as she was getting to the conclusion that probably she was not going to row as a lightweight. So in this case, we didn't ban her from finishing her spring season, but we did need to take a long-term approach with how we were going to protect her bones as we were changing her mindset about what was realistic as an athlete. And ultimately, after 2 years, she realized that rowing as a lightweight didn't make sense, and she decided to keep training, but to try to become an open weight and see how fast she could get. We did a paper comparing the different tools, basically comparing the Triad cumulative risk assessment and the REDS clinical assessment tool. And this is a little hard to follow, but basically you can see that we gave it a high risk, moderate risk, or low risk category scoring with the colors, and then they fell into the Triad risk of high, moderately, low, and the numbers didn't completely add up. So they weren't always consistent. But overall, what we found was most of the sample was assigned to moderate or high risk for Triad and REDS. And the tools agreed on risk for 55.5% of the athletes. Agreement increased to 64.3% when we just talked about the ones that had DEXA tools available, so that we had DEXA data. And Triad, CRA, and REDSCAT provide consensus on the majority of athletes at an elevated risk for low EA, but have less agreement on the specific risk level, meaning it was pretty good at catching moderate and high risk, but not necessarily differentiating if it was moderate or high, just kind of catching that those were people that should be investigated. Future directions include studies that explore other health and performance effects of low energy availability in female and male athletes, studies determining efficacy of return to play protocols, comparison of treatment approaches for eating disorder and disordered eating in athletes. So complete exercise restriction versus reduced exercise, that's a big debate. Psychotherapy early, so what type of psychotherapy? Some people respond better to FBT. Some families don't want to do the family-based treatment and the patient will do better with CBT. We need to look into that more and see what the differences are in some of our athletes versus all REDS patients. definitely definitive hormonal and other therapy studies, and further research on the consequences of energy deficiency in both females and males. Finally, more awareness and prevention programs and just making coaches, athletes, their entourage, their providers just much more informed about the issues. So that's it. I am now happy to take any questions, and I think John is going to conduct that part.
Kate, that was exactly what I expected to be, absolutely thorough and a great insight into a relative energy deficiency in sport. I think that the two take-home messages for me are how thorough you have to be in exploring every aspect of the syndrome potentially, and secondly, how much this lends itself to a multidisciplinary approach. You know, we often talk about that, but we don't often implement it enough. And I think as clinicians, we need to learn to work through these things in a multidisciplinary way. So thank you very much. It was exactly what we wanted. And we've got some great questions that have come through. I'm going to start off with one, asking you about athletes who suffer from this condition in their young adult lives, maybe 18 months or 2 years worth of it, significant amenorrhea, drop off in performance, and then they seem to recover well. Does that compromise them going forward? So 15, 20 years later, if they want to run half marathons, and are they at increased risk then, even though all their clinical parameters seem to be normal at that stage? Have they compromised themselves forever?
So we definitely need more longitudinal studies to answer that more accurately. I can say anecdotally, when we have caught it early and we've been able to improve the bone density because we've caught it early and we've caught them young enough that they're still accruing bone, and we can turn that around and do a little bit of catch up, they can be absolutely fine. If they've done a lot of damage early on and they haven't made the changes quickly enough, and they're, for example, coming to see me at the age of 30, we might not be able to undo all the damage. So really, the most of the medical issues are fixed except for the bone density issue. So if the eating disorder is gone and all of those other parameters and hormones are fixed, everything is pretty good, except the bone density will always put them at a higher risk for fracture if that's not corrected.
Great, thanks a lot. Haley?
Hi, yes, a few questions from our attendees. Firstly, there's a few been regarding the different diets, and really wanting to know from you, is there a difference between where they're getting their calories from? So for instance, a keto versus a low carb versus a high carb diet, what does that do? How does that influence the prevalence? And then for the low carb diets, how does it change according to an acutely low carb diet versus a long-term low carb diet where there's a bit of fat modulation or regulation, adaptation?
Yeah, so I think the people you want to have talk about that are Sungit Borgen and Jorn Sungit Borgen and Louise Burke are probably going to be your dietitians and sports scientists that are really going to answer those questions in more detail. But what I can say is one of the questions that we're interested in exploring is transient weight loss or transient energy deficiency. We know that most elite athletes need to go through phases for short periods of time. And my collaborators and I, including the ones that I just mentioned, are interested in studying what happens in that inter-day variability in those short periods of time. We think there might be a little bit of a detriment, but not nearly as much as if it's a prolonged energy deficiency. And then for the type of diet, we've done some work with Louise Burke, who's done a lot of work in this area of keto and looking at endurance athletes. And we see that there are changes in bone turnover markers that are not favorable in people that are following keto, at least for short-term measurements. So when we've looked at race walkers with Louise's group, we found that the bone turnover markers were not favorable in those who are on a keto diet. So I do think that those diets make a difference. In our study, again, surveying those 1,000 patients, we asked them about dietary practices and if they were following specific diets. And it can often be just a marker of somebody who has, not saying that everybody on a diet has a disordered eating pattern, but we found that there was a much higher correlation with people who are on diets who screen positively for disordered eating. So keep in mind when you're seeing a young athlete who's 14, 15, 16, and she says she's vegan, or he's a vegetarian, or he's doing keto, sometimes that can be a way to eliminate certain foods, and that can be a bit of a red flag. So it should just be explored. And that's where I'd recommend that people meet with their sports dietitian. If they're deciding to be a vegan or vegetarian, at least do it correctly. People can be on those diets for a variety of reasons, but they can be red flags.
Thanks, Kate. I think that's great advice. We have some more questions around contraceptives. And then especially in light of today's contraceptives, where often there is no cycle that goes with the contraceptive. One of the questions was where you mentioned swimmers with irregular cycles had slower times. And they just wanted to know that the estrogen through the contraceptive, is that adequate energy? And would that affect the times or their speed?
So if you have anybody on an oral contraceptive or any contraception that's going to mask a menstrual cycle, you don't really know what's going on with their energy availability. And that's the biggest issue. In these studies, these were all people who weren't on birth control of any type, so that the hormones could be actually tested. So we're using energy availability markers in a normal person who should get a period. One of the markers is amenorrhea. And if you don't have the ability to find out if someone has amenorrhea because it's masked or they have a fake period by a pill, you can't really say. You're certainly not giving somebody estrogen through a pill and having that lead to improved energy availability. You're simply giving some hormones to a person to protect them from getting pregnant. Okay.
We've also been asked, just with the amenorrhea, if the implications on the older female athlete who has no prior history of any REDS flags, that type of thing, is like coming to performance sport at a later stage, say the 30s. Are the issues similar? Obviously, they would, not be at risk of a low peak bone mass, but any differences you could highlight or anything that they should be aware of?
So I think it depends. So if the person is coming, let's say you're 30 and you go to the doctor and you're not getting your period and you're on the pill, it may just be because the pill is causing you not to get your cycle. But it's important, if you really want to know if that's the case, to get off the pill. And if your energy availability is adequate, over time you will get your cycle back. So it's fine to be on a birth control pill if your energy availability is normal. There aren't any studies that say that the pill is detrimental in somebody who is fueling properly and has normal energy availability. But when you have a patient where you're questioning if they have adequate energy availability and they're taking the pill, you have no idea, because the pill is either causing a fake period or it's suppressing a period. You really don't know what's happening physiologically, and you can't test the hormones while they're on the pill. So I always trial people off of their pill if that's the question that they're asking, and they need to be off the pill for at least 6 weeks before you can test hormones.
Okay. There was also a question around any research with tendon issues and low estrogen.
Yeah, there definitely are questions about different hormones affecting tendon strength. And so it seems that estrogen does affect estrogen, estrogen, progesterone, relaxin are all hormones that affect strength of tendons. We're still trying to figure out the sweet spot in terms of the hormonal cycle when people are more susceptible to injuries, but that is sort of an area that still needs to be investigated more. I'd say Ellen Casey, who's a doctor at HHS, the hospital for, or HSS, hospital, what am I trying to say? HSS in New York. She's a PM&R doctor who's studying a lot of the effects on tendon. And so Ellen Casey's research would be a good place to look. It's not a completely answered question yet.
Okay, interesting, thanks. We've also been asked, what was the main barrier in your first case study of the patient needing to be admitted rather than embracing your advice or the advice and moving forward with that? And with that, we've also been asked, do you have a suggested strategy to actually motivate the athletes in making a shift, a change?
So that first athlete was very young, and we didn't have buy-in from the mother yet. So the father was never around. The mother was there and wanted her daughter to be a prima ballerina. And so we were walking a fine line between admitting this child against her family's judgment, which gets into a legal complication that we didn't really want to go to, but we were prepared to if we needed, versus getting enough information and proving it not only to the child, but proving it mostly to the parent so that she could see what she was having her daughter do is detrimental to her future, that she was never going to become a prima ballerina if she kept starving herself and staying this small. So much of the time was really aggressively trying to educate the mother who thought, no, you don't understand. The mom was telling us, you don't understand. Dancers are very thin. Dancers are very small. We don't want her to grow too much. It was a really tough case because we were pushing against a parent.
Okay. Any strategies that you use that work well to shift the thinking?
Yeah, I mean, I think that's where I really like the REDS model. Because again, that mom wasn't even listening about the fact that she was going to have future fractures, which she did. But we spent a lot of time talking about what her performance was like. Did she have a lot of energy to get through her dance practices? What was she looking like? Was she jumping as high as she wanted? So I think the REDS model, when you start talking about the performance consequences, when you're dealing with parents or athletes that are solely focused on the performance output, can be really helpful. I had a patient last week that I had to admit directly from clinic, and this was a young lady that wanted to go to the Olympics, and she was 14, you know, and I had to really reframe this in a really sick girl to say, there is no way you're getting there yet. We got to take care of this part of your training. We got to get to the caloric intake and build your bone density and get you stronger. You're not going to be able to train like an Olympic athlete does. So often it's just framing it differently to have it resonate with them in terms of something they really care about.
Okay, and then one last question. We've just been asked, and I think it's a helpful one for all of us, how long should we expect it to take once we've restored the energy to see the hormonal cycle and levels come back?
Yeah, so that's so tricky because especially for athletes that are working really hard on correcting, I tend to do a general weight goal. I don't just tell them to gain weight till they get their cycle back. That will make them very unhappy and it's not really necessary. So in general, vaguely, what I typically shoot for is a BMI of around at least 20. This is just general. And if I have the percent fat on the DEXA, I'm typically trying to make sure that their percent fat Z-score gets above -1. Similar to bone, we're finding that just anecdotally, we're looking at all of our patients and seeing if this is coming true. But basically, if their Z-score is below -1, people typically don't get menstrual cycles. We're still trying to figure out the right Z-score for men. But the goal is to get them to that weight where their percent fat Z-score is typically above -1, their BMI is 20 or higher. And then I have them sit there and don't ask them to gain weight, but just kind of hang out there. It could take 6 months or a year. It usually doesn't take a year, but the longer somebody has been energy suppressed, the longer it takes for their period typically to come back. And that's why I frequently use the transdermal estrogen so that they're not worried about that. They're not judging their success or failure based on the period coming back, but they're getting to that weight goal and then they're just hanging out. So it may mean we give them a few months to correct it. It's taking a while. We put them on transdermal estrogen for 6 months. They get their weight to where it should be, live there for a while. We get them off of that transdermal estrogen and then they get their period. And then everybody's happy and they didn't waste time waiting for it and they didn't have to think about it every single month.
Thanks. That's some practical advice and a better way, I think, of having more measures to measure it with, if I can put it that way. Thank you so much. John, I'm going to hand back to you to end off.
Okay. Thank you, Kate, very much for everything that you've done and for the preparation. I want to promote 2 things. One is your Twitter handle, to let people follow you on Twitter. I think lots of words of wisdom that come through there. And also that female athletic conference. I think it's going to be worthwhile if we're allowed to travel by then. Who knows? It's such an uncertain world, but it's certainly one that I'd like to get to. So we thank you once again for all your trouble and in preparing this talk and for giving up your time in a very, very busy schedule at a busy time in your career. Thank you to Haley. Thank you to our sponsors again. to support us. And I'm going to hand over to Robin to just put the last slide up, which importantly has a link to the WISH website where you can get a lot of this information. So thanks very much, everybody, for attending. And we look forward to seeing you again next week for our next webinar. Thank you.
Thank you.